Hey folks, this is Ray Kober. If you haven't done so already, please click that subscribe button below. That'll help us get better guests and make the show better for you. So once again, click that subscribe button, join us for this journey, and together, let's make healthcare better for everyone.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host. And on today's episode of the Broken Healthcare podcast, we sit down with Jeff Back, the CEO of Imagine 360, a company that's not just disrupting the status quo, but rewriting the rules of employer-sponsored healthcare. Jeff brings a sharp perspective shaped by decades in the business, and under his leadership, Imagine 360 has evolved from its ELAP roots to become a fully integrated end-to-end alternative health plan, one that slashes costs and improves the member experience. We're talking about how to go from PPO dependency to sustainable, transparent care without sacrificing quality or access. If you're an employer, a broker, or just someone who's tired of watching healthcare costs climb with no end in sight, this one's for you. Let's get into it. Welcome to the big show, Jeff.
Thanks, Ray.
Yeah, man.
Glad to be here.
Great. Great having you with us. So tell me a little bit about Imagine 360, because as I said in the intro, you started out as ELAP. The founders of ELAP eventually sold, were acquired. How did all that work? When did that go down? And then let's talk about the roots of ELAP, which really was a pioneer in reference-based pricing.
Yeah, so Steve and Woody had ELAP, which they founded, and maybe it's about 8 years ago, took an investment from a private equity group called Water Street Health Partners out of Chicago, very healthcare focused. I think for Steve and Woody, it was a way, one, to recognize the efforts they had put in and get some liquidity, but more importantly, to help them grow and scale that business. And it was primarily ELAP doing reference-based pricing, and they really were the founders of that, trying to not just reprice at a different level. You know, the theme was Medicare plus 20, cost to charge plus 12, the greater of those two. It's usually 140% of Medicare on average. That foundation allowed them to save a lot of money for employers, and so anywhere between 20 and 30%. And it's easy to reprice. It's hard to hold the line and defend those reimbursements. And so they had a pretty sophisticated way of supporting employers and members if the provider decided they didn't want to take 140% of Medicare. And that DNA is still with us today. I mean, at the core of what we try to do, whether it's out-of-network claims, whether it's in a dual option where you can have a broad panel PPO product and offer an RBP product, the ability to make sure that members can consume care and have access to care. Like the two biggest things you hear about reference-based pricing, we all know this, right? It's you'll never be able to see the right providers. And on the back end, they're going to balance bill you and hassle you and debt collect you until you acquiesce. And, you know, while that can be true, the percentage of times it happens is so minimal these days, and we manage it probably better than anybody out there, that I think it's worth re-looking if you haven't looked at it as a broker or as an employer or a CFO or a CEO. It's worth reinvestigating where reference-based pricing is today versus where it was when Steve and Woody founded the business.
So let me cut you off there because there's a lot to unpack.
Yeah.
Right? So reference-based pricing, for those who may not be aware, if you're a mainstream broker and you don't mess around with self-funding and that's not your acumen, your purview, what you do typically as part of your analysis, you may be unfamiliar with, but I think it's probably highly likely that if you're in the broker game, you know what RBP is. But certainly if you're a CFO, someone who's not in the business of healthcare, you may have heard the term RBP, but not really know what it is. So take us back to kind of the beginning of when your founder came up with this idea and what exactly it is, because it's important for, I think, leaders to understand what this is and demystify it, because I think there's a lot of, I don't know, it's almost like voodoo magic. And it really it's not, right?
Right.
But I think that is, the perception. So zoom out, if you would, and tell us what is precisely what reference-based pricing is. Where did this concept come from? Who the hell is your founder, and how did he have any business?
Yeah, right.
What was his thought? Like, why did he think that he could actually get this done?
Yeah. So Steve Kelly was in the stop-loss arena prior to founding ELAP. His partner, Woody Waters, was more of a broker, property and casualty broker.
Okay.
They looked at some of the performance from a stop-loss perspective and pretty quickly saw there was a huge disparity in what hospitals were getting reimbursed in a broad panel PPO network.
And stop loss, Jeff, I'm sorry to interrupt you, but just to dumb it down, I had some very astute guests last week that have long histories in HR, and they're like, I don't know what the hell stop loss is. And I didn't take the time to explain it to them, but if I really wanted to dumb it down at a higher level, could I say that stop loss essentially is, you think of it the same way that you would a deductible in your insurance policy. And essentially, you are insuring risk beyond a certain point. Up to that point, the employer is on the hook for whatever that expense may be. Beyond that point, your insurance policy picks up, and it's going to pay. Is that fair enough, or is that?
No, it's a great example. It's a 3-tier. You have your employees who take the first tranche of risk, then the employer takes the second tranche, and then you have a stop-loss partner who takes the third tranche, and that could be on a specific individual through the course of the year, or if the group is performing really poorly, it could be on the aggregate of the entire performance of the group. So you have two ways to protect yourself as an employer when you work in the stop-loss market.
Okay. And an employer, I'm imagining, can determine, okay, I am happy accepting responsibility for the individual, but if we have a huge claim that is a multi-million-dollar claim, we want to know that we're protected. So the employer, along with guidance, I'm sure, from their broker, is going to determine what is the appropriate stop-loss coverage for them. Would it be spec? Would it be ag? Would it be a combination of the two? That sort of thing.
Correct. And it's very formulaic, and everybody has a different risk tolerance. But, it's depending on the size of the business.
Yep.
The historic claims, view and what that has performed and what it's done.
Yep.
You can get a pretty good read on what you should expect. And there's an expected. And so the thing with stop loss and, kind of this concept of self-funded is there'll be a price or a target of expected total claims. Mm-hmm. And then there'll be the maximum total claims, which are typically 25% above the expected. And a lot of new people and employers in particular and CFOs look at it and say, well, it's going to be the worst case scenario. So we're going to have to fund and we're going to have to have people contribute at the max. And that's not always the greatest approach because the max should happen very infrequently. 6% of the time we should see a max hit claim where typically it should be on the expected. And the biggest driver of those outcomes generally are hospital claims when you get back to it. I mean, back to where we started here from a reference-based pricing perspective. And so stop loss is a vehicle to help. But the thing that Steve Kelly saw that I think got the ELAP thing rolling is in a market like Tampa, there's maybe 6 or 7 hospital systems. And each one has a different contracted network discount that they've given either Cigna or Aetna or United. And they were taking the stop-loss risks. So they were on the hook, so to speak, when claims got really expensive. And what they saw was there was a 3 to 5-fold variation between one hospital and another on what they were getting reimbursed. And because they were the ones stroking the check above $25,000 or $50,000, it was really important to them and their loss ratio. And what they saw was there was no relativity to quality or location. It just was. And so the employer didn't know there was a 5-fold variation with those hospitals in Tampa. The employee didn't know, but the stop-loss underwriter knew. And that was a wake-up call for them to say, there's got to be a better way to figure out how to reimburse hospital systems than the way we're doing it with today's approach. Broad panel PPO, discount off of billed charges. Those billed charges have no relativity to what it actually costs them to provide the service, and it goes up every year.
Yep.
So this was a way to say, hey, how do we make the way we reimburse hospital systems sustainable? If we pegged it to their actual costs, they have to publish their costs to CMS every year.
Okay.
And so like any business, you say, hey, what's a fair margin over your cost? And we looked at that and said it's probably 12%. So let's look at the cost it actually takes the hospital to provide the service and add 12%. Or we'll take Medicare, which is the largest payer in the United States, right? All of our parents and grandparents are on Medicare.
Yeah.
We'll take that and we'll add 20%. And we'll take the greater of the two. And half the time it's the cost to charge plus 12 that we reimburse. It winds up being, probably 160 of Medicare. And then the other half the time it's Medicare plus 20%. And you average those two, you wind up at Medicare at 140% or 40% above Medicare. And I'd say the average PPO discount that you see in a broad panel PPO is probably somewhere in the 250 to 300% of Medicare. RAND did a big study, and it's out there. Every state, has a percentage of Medicare that their average reimbursement in a PPO network recognizes. And Indiana is one of the worst. They're way up there. It's probably 4 or 5 times Medicare. And in places like Maryland, where they have heavy regulations on what you reimburse providers, it's like 130% of Medicare.
So there's a lot to unpack there. Starting with what strikes me is getting back to stop loss and the expected versus the max. 6% is a very low number. You mentioned that it's less frequently than 6% of the time a company will go through its max out of pocket. Now, is it appropriate for me to think about max out of pocket as the equivalent of what you would pay in a fully insured plan? So that's one question. And then supposing that, so here's where my mind, is going. I'm looking at this and I say, okay, let's suppose a broker comes in at time of renewal and the insurance carriers are looking for modest increases. Let's say they want 10%. Which is a relatively low number, or if you want to call it average, we'll call it average. And they would then do a side-by-side comparison with an Imagine 360 proposal. And you might have various options, but let's suppose for the sake of argument that one of those options, it breaks down. This is what your expected costs will be, your total all-in costs, including claims and administrative expenses. This is what your max costs are expected to be. So in no universe, if I'm thinking about this correctly, will the client be responsible to pay more than max claims as long as they abide by the SBD and the rules of the plan? So first and foremost, is that accurate, and is that an appropriate way to think about it in comparing it with a fully insured plan?
I think so. That would probably be the worst case scenario. It might not be a fully insured, might not be 125%. Maybe it's closer to 120, 118, in that range. And so because the max doesn't typically happen and they want to still be competitive, and so they're going to be somewhat mindful of how to absorb that 10% renewal increase and not make the fully insured premium commensurate with the 125% of expected. I would say on an apples-to-apples basis, if you're looking at a fully insured type program and you're getting a 10% increase, so it's $100, now it's $110. If we were to do that in a self-funded environment with reference-based pricing, you would probably start at $80. Just macro by way of thinking about it.
Sure.
And what happens a lot of times with us is we have a expected that we don't always agree with, that the stop loss underwriters come up with, because they may not have a lot of experience with reference-based pricing yet, or they may not have a lot of experience with our direct contracts.
Right.
And so they still have some conservatism in their underwriting approach. And so what we've often done in this very example, in this very case, is say to the client and the broker, listen, we believe that you're going to save money. And we don't think there's going to be a chance you get to 125. So we're going to do a guarantee, a warranty. We're going to put a warranty in for your stop loss for your first year that you will not exceed 110. And if you do, we'll make it up for you dollar for dollar. So you can, from a CFO perspective and a broker perspective, say, well, they're so convinced that this is going to work and we're going to save money that 125 is not going to happen. They're going to buy it down to 110, and they'll underwrite you between 110 and 125. So you can set everything at 110, and that's going to create savings and first-year improvement, and also hopefully have a little bit of bank to take into the following year and some reserves you can use and lean into without ever having any control over this. That's the big thing is you had a checklist before we got going today,
Yep.
right, with a lot of things on it. And I'm sure you didn't do that. That's not the first time you did it. And I thought it's taken.
Right.
You've had a lot of, boy, I wish I would have done this. I wish I would have done that.
Right.
And got to a point now where you're like, all right, I know what I know. This is the method. This is what I do.
Yep.
There's no difference in when you buy healthcare, health insurance.
Yep.
You need a 3-year plan of attack. And if your goal is to recruit the best people on the planet and you don't care about anything, any cost, buy a PPO. Do fully insured.
Right.
Everybody will be happy.
Right.
Hospitals will love you because you're going to pay them really well. Brokers love you because you're going to get a nice commission. I mean, it's a wonderful product. It's just I can't afford a private plane and I can't afford a lot of things, and I have to figure out how I can afford for our company at Imagine 360. We're on it.
Right.
So we are on reference-based pricing. We have direct contracts. We administer our own benefits. We have our own captive, so we insure ourselves.
Yep.
And that's what we can afford as a company. And we've seen our renewal increases steady in the, you said 10%. I know that's the norm. But, Medicare has been increasing at 2 or 3% a year.
Right.
And since that's our benchmark and how we reimburse on a lot of the services we provide,
right.
we see probably 3 or 4. And for our company and for a lot of companies like us, we work with a lot of auto dealers and transportation companies and surprisingly, a lot of healthcare groups. We have several hospitals we work with, doctor groups, because they kind of understand the way this crazy healthcare thing works and the reimbursement methodologies that are out there, and the fact that they don't want to be the ones that are overpaying, because they know that in that broad panel PPO, when you're discounting off of billed charges, it's a winner for the hospital systems. And why do small, mid-sized businesses have to be subsidizing hospitals, P&L?
Right.
They shouldn't. I mean, the unions don't.
Right.
Right. Many times, a lot of the Taft-Hartley plans are not. They've done some direct contracting and some pretty creative things. The ACA doesn't. Right. When you buy an ACA product, that reimbursement's substantially lower and tied closer to Medicare and Medicaid, somewhere in that range. It's only the self-funded commercial market that is paying the highest freight, and I don't think it's fair.
Yeah. Well, and really, it's folks that are it's organizations that have their caboose connected to the fully insured locomotive, I think, that are paying the highest rates. And that's typically what I tell my clients and my prospective clients. If you want to pay the most that you can possibly pay for healthcare, get into a fully insured plan. And, I think you do a fair job of laying it out and saying, if you don't want to have any risk, you don't want to have any worries, you want to make everyone happy, then sure, by all means, enroll in a fully insured plan. But to your point, the reality is people can't afford it, right? So we're at a place now where, I don't know, what the average cost of care, the last time I checked, Kaiser Family Foundation is hovering right around $17,000 per employee per year. That's a huge number. And then when you start to think about, okay, how much of that $17,000, if I take away the outliers, what we call the super utilizers, the 1% of your employees that consume 30+% of your claims, the 5% that consume 50 to 60% of your claims. If we carve them out, how much healthcare, actual healthcare, is the rest of our population consuming? And unfortunately, most employers don't approach or look at it that way. And I understand they have businesses to run, right? They're running investment, and banking firms. They're running construction companies. They're running nonprofits, hospital systems, et cetera, et cetera. But if they're in one of those plans without any cost containment mechanism that is not using Medicare as a benchmark, or to your point, 12%, cost plus 12%. And by the way, Jeff, do you know? I'm not even sure that you know. Why is 12% the magic number? Is that enough to make them happy, or is there science that goes into that 12%?
I think the science was if you're sitting and you're debating, or you're having an arbiter declare whether that's enough of a reimbursement or not, because oftentimes these things can get contested.
Yeah.
And if you were the hospital CFO and I was ELAP, and we were talking with a third party here about what's fair and reasonable, in the ERISA framework, you're supposed to be a fiduciary, and you're supposed to look out for the plan and not overpay, and be fair and reasonable. And so the conversation would go towards, we're paying you. Do you make money on Medicare? Yeah, we make money on Medicare. Well, we're paying you 40% more. How much more do we have to pay you until you say it's okay? And they're like, well, we want to be more subsidized because we've got more Medicaid folks, or folks who are financially, unable to pay, or whatever the case might be. And
right.
We've looked at it as a very defensible reimbursement, and we've been contested both in court and in arbitration, and with the new surprise balance billing and the qualified payment amount. And it's held up. So we think it's a pretty good number.
Excellent. And so ultimately, that number is you're just really trying to dial in. So there's no exact science, right? You're just trying to dial in what is a fair reimbursement, so that the entity, the service provider, the physician, the freestanding clinic, the hospital is able to, not only earn a living but thrive, right? You're not saying we're trying to cut you off at the knees. And I know that there are a lot of hospital administrators out there that claim that they're underwater and they can't make money on, Medicare services. I think in my experience, what I've found is that the best run healthcare systems actually do make a tidy profit on, the Medicare reimbursement rate. And I think it's more a function of operational efficiency. I could be off base, but I think it's more a function of operating efficiency than you're just not getting reimbursed enough. And what I'm hearing you say, and I think it's not unique to Imagine 360, but most organizations that are out there that are working in an RBP environment are generally kind of in that range. Maybe they'd like to reimburse at 120% of Medicare, but it's probably more in that 140 to 200 range that is the sweet spot. And I would think if you go to court and you put this before a judge, and the judge is given all of the facts, he'd be pretty hard pressed to rule in the favor of a plaintiff for paying a 40% increase over what they get from their patients every day.
Yeah, we agree. And I think there's a distinction that sometimes people forget. So we actually wind up paying the doctors, the primary care doctors, the specialists, a bit more than what they get paid in a broad panel PPO. So for the docs, it's a pretty good deal because we don't feel it's like 90% of the claims, but only 10% of the dollars spent from a claims perspective.
Yep.
And you want to have access to care. That's the most important thing. And so we overpay the docs. And this reference-based pricing percentage of Medicare thing is what we do with the hospitals for inpatient, outpatient. And because that's 90% of the claim dollars, but only 10% of the claims. And so when you start looking at all that coming together, it's a very small percentage of time where we have to have another conversation with the facility and work with them before they'll see the patient. We call those single case agreements. It's a negotiation. We go back and forth. They generally settle out somewhere around 250% of Medicare. I'm not talking about the centers of excellence, though. Places like Cleveland Clinic and others like that, nobody has a great deal there because they're really good at what they do. And their cost to charge ratio isn't super exaggerated because they do it over and over and over again. And we all relatively pay about the same price for things like oncology and heart transplants and things of that. This is your community hospital right in your backyard that we're talking about here.
Yep.
And so those two things, I think sometimes people don't recognize that the heavy transactions, the high percentage of claims, it's relatively small dollar, and we overpay in those situations so that we kind of save our dry powder for that contest and support and fight on the big dollar stuff, which is what winds up hitting stop loss pretty significantly. And the other thing that Steve Kelly did, back in the day, is they had the PPO contracts for some reason have things called an outlier provision. That means that, hey, we're going to give you 50% off of bill charges typically. But when you get somebody who's really sick and it's a complex care case and they start having multiple issues and they wind up having $50,000 or $100,000 or greater of services at the hospital, there's something called an outlier provision that gives them the ability to actually reduce the discount to get paid more because it's complex situation, and it really hurts stop loss the most because they're at that point they're 100% on the hook for these claims, and they're going to take something that they may have had a 50% discount on, it's going to maybe reduce to 30, and so they pick up that difference, or the employer does, right? And that's another thing that people don't always recognize, that when you kind of need those discounts the most, there are situations where there could be exceptions. And it surprises a lot of people.
Interesting. So when I think about this sort of stuff and I think about who's on the other side of the equation, and what I mean by that now is I'm referring to the insurance carriers, right? The insurance carriers, the BUCAs, as we affectionately call them, the Blue Cross, United, Cigna, et cetera, of the world. Are they looking down? Are they giving hospital administrators heat for essentially giving an RBP vendor a better discount than their negotiated contract? Is that stuff that creates difficulty for you at all, or is that kind of outside of your purview?
No, I mean, they're competitive. We compete, and when we win a case from a United or Cigna, they're not happy about it, and they'll be the first to, raise an issue with a particular facility about why are you allowing them to use your facility in the first place, and those reimbursements are too low. And in some cases, it's enabled us to actually have a conversation with the system and do a direct contract. And what we do in those situations, like in Pennsylvania and Philly, we have UPenn, great system, high quality, really good academic medical center, and we have a contract that's very competitive, and so it's enabled us to do some things that historically we haven't been able to do, which is let's steer as many people as we can in that area to UPenn facilities and UPenn doctors. We know we have a nice contracted rate, which is still better than what the average PPO would be given. They asked us, like, well, how will we know if you're successful? Like, how can we measure you that this is working? And we'll say, well, let's look at the utilization on this book of business, 20,000 people, and see if they drive further to your facilities, to see if when they do have something that's material, are they going to do it within your framework or go outside of your framework? And so what we saw is that we had more utilization, and that was at the expense of their competitors. And the drive times went up, not substantially, but 20-30%, which is big in a metropolitan area,
Sure.
right? You're willing to make an extra step, and so it was good data, good feedback. We have a growing relationship with them. We have probably 20 other markets where we have a similar relationship. Where if you have to have a contract, and you can't get your head around the fact that you can go somewhere without a contract, we can accommodate, and oftentimes we do. We'll put an anchor client with an anchor system, so that they, HR and the benefits team can look the team in the face and say, well, if you absolutely want, no hassle and no consideration and everything to be the way it was in your PPO, go here.
Yep.
Logo on the card, you can see it. But if you don't go there, then we're going to really hold the line and use the reference-based pricing approach on pricing, because we don't have a lot of other contracts.
Yeah.
Right. And so, but there are we have some relationships with our one hospital account.
Yep.
So they're primary and they call it domestic, and they want their employees to go to their own facility. Surprising, right? Yeah. But they weren't
Right.
using their own facility as much as they should have or could have. We tweaked some of the contributions. We moved some of the deductibles down and added a copay in order to incent them to use their domestic facilities, which they did. And then we put a layer in, which was PPO.
Yep.
So you could go now to another provider. If it's a PPO contract, great. But if they weren't in a PPO, then we would use reference-based pricing on those claims. And so what we found is, the utilization went from 40% up to 55 or 60%. So a nice move in the domestic tier, we call it. And we saw, quite a bit more savings, because they were paying themselves a lot less than they were getting reimbursed in the PPO contract. And when they go out of network, we were able to save them quite a bit of money with our new kind of reference-based pricing approach. So it's funny that, sometimes when you go, they become, you're competing against them and you're butting heads, and then the next thing you know, you're a business partner and you're making stuff work. And that's just the crazy thing of healthcare, is that you could be competing 1 minute and fighting the next, like a family.
Yep.
And then ultimately it winds up being a good guy and things work out.
So how you lost me on business partner? Who are you referring to in that scenario?
So us with a hospital system,
Okay.
right?
With a hospital system,
We've
sure.
contracted. Right? We've been kind of butting heads because they want to get reimbursed more. We won't do it. We're holding the line.
And now you're working alongside
Now-
them,
now we have a
figuring out a
contract.
way how to drive more utilization to their healthcare system. And you would think that everyone wins in that scenario, right? The patient is winning. Hopefully, they're getting high quality care. They're getting it at the best price possible, and they're kind of feeding into their own ecosystem.
Yes.
Right, which is the whole concept of community run healthcare systems.
Right. The big question we had with that hospital system was, why are you paying your competitors more than you're paying yourself?
Yeah.
Right?
Sure.
That doesn't make any sense, right? So at least pay them what you've been paying yourself, not
Right.
more.
Right.
Which was a bit of an eye opener.
Yeah, for sure. So when I think about the orchestration of this, how many employees do you folks have?
At Imagine 360?
Yeah.
1,500.
So it's a good sized company.
Yeah.
Who is actually doing the negotiating with the providers? And is that a very convoluted process? Is it give me an example of who in your organization, not by name, but just by title. What is their title? And what does that engagement look like? Like best case scenario, worst case scenario, just to give our audience kind of a flavor of what's happening behind the scenes.
Yeah. So like a traditional insurance company, we have the same kind of resources doing many of the same things.
Yeah.
Where it differs is when we have somebody that has gone to a hospital, has gotten a claim, we've reimbursed, and the hospital wants a little more. So that falls into our advocacy team, which is a team of people who handhold the employee and their family through that whole process. And so what we do is we reach out and start negotiating to see if they're willing to accept any more. And by the way, I should say this, that about 3% of the time, the hospital system is coming back to us and not accepting the reimbursement. that means 97% of the time has been accepted.
Right.
And so in a way, you've already won because now you've got house money because you've saved 20% or more
Right.
on 97%. So how do you adjudicate and handle that 3% in the most fair and equitable and expedient way possible?
Right.
So we have really good people who
Is it always the CEO's wife or husband?
Of course.
That's part of that 3%.
Yes, of course.
Always.
Absolutely.
Never fails.
Never fails. Yeah.
Yeah.
And so there's, in addition to wanting to do the right thing, there's, giddy up on getting it done. But you have to follow a process. I guess that's part of it because we educate why we reimburse what we did.
Yeah.
From a self-funded plan, fair and reasonable, rationale in terms of other data points in your market as to where Medicare is, and lay it all out from a legal perspective, and say, and we also have a fiduciary responsibility to be fair and reasonable, and what you built, what you want us to pay you now, which is the entire build amount, is not going to cut it.
Yeah.
So we kind of have a range. We start and work our way through maybe up to 200 or 250% of Medicare, and if they just say no, it's all or nothing. We educate them further that we think we have reimbursed you fairly. You've cashed the check, you've got the money, and we are going to stand firm and not going to pay anymore.
Yeah.
And that process can take a while.
Sure.
I think we've gotten to a point where if it's small dollars, under a couple grand,
Yep.
We've done the math, we've looked at it. We'll use our own capital
Yep.
to make that go away.
Yep.
Not the plan. We'll do it on our nickel. Because it's just the small dollar stuff isn't really where the savings is, but it's where there's some noise.
Sure.
So on the larger claims, we're going to take a stand and we're going to defend those. I will tell you that very few times does it lead to anything more than just some form of a settlement and some form of a payment, which is good enough. We're not in the business of getting people's credit dinged. That's a big thing, not having that happen. So we have a playbook that if they're going to try to collect on you, we'll accelerate our negotiations and we'll figure it out. And oftentimes, we'll even be the ones to cough up the difference between what the plan has agreed to pay and what the hospital system wants. But you're dealing in a very small percentage, and we really handhold that member or the family member throughout the entire process. There's I think we talk to them every single week. In terms of where things stand.
Okay.
So they're very educated, they're on board, and they're actually kind of, if they know they're not on the hook for it, they're actually looking forward to see how this thing plays out. And oftentimes it plays out to our favor. I would say 70, 80% of the time it does. And they're somewhat fascinated by the fact that just by saying no and just by educating, you're able to save me and our company, $10,000, $20,000, $30,000.
Sure.
And so they kind of gets them now they're a part of it. They're not just the user of it. They're like, hey, this thing actually works. How do I, all right, next time when I go, should I go to a different hospital? Or, why don't you give me some advice? Who accepts this all the time without any type of interference? I'm happy to, make that consideration. So that's a group of people we have at the company that you wouldn't see at a typical insurance company. And the other group is a group of people who handle front-end access to care.
Got it. And so these folks in your organization are actively, I think it's probably fair to say that they develop relationships with administrators of these healthcare systems. So it's not often that it's, I'm sure it is some of the time, it's kind of a call out of the blue. Johnny calling on behalf of Imagine 360, and we have a patient, we'd like to work with you on this. I would imagine that's kind of how the framing of the conversation goes. And is part of the advantage of working with you guys the fact that is there expediency in terms of time to money versus a typical insurance carrier?
We pay very quick. And so there's some value. I think the systems do recognize that we're a fast payer.
Because that could be a real carrot for a healthcare system,
That's right? Right. And we also, when we do have settlements, we can also ensure that the member or the family pays their full freight. because oftentimes, as you know, they won't.
Yep.
And there's a whole process for hospitals to go collect that money in addition to what the plan owes.
Sure.
But yeah, it's fast pay. I think on the other side, this other group, to your earlier point, they have those relationships. They know who to call at a hospital system when somebody doesn't recognize their ID card and they want to access care there. And they're pretty good at ferreting through quickly. Here's what we reimburse. Is that acceptable? We want a little bit more. How much more do you want? They'll negotiate. They're really good at it. It's kind of a unique skill set. They speak the same language because a lot of those folks came from a contracting world and entity once upon a time, either at a BUCA or at a hospital. And they can kind of get to the quick pretty successfully. And we track, almost every day who is waiting to access care and what's it for, and what's our status with that, and when will they have resolution there? Because that's where you really want to, I think, shine. That's where we kind of super hustle with a lot of determination to get somebody in.
Yeah.
And so what we've done is we've figured out that sometimes they'll take cash pay. So we have a virtual credit card that we can pay immediately to that provider so somebody can get in either now or tomorrow or when their appointment comes in a month. And we get a pretty good discount for that. It's a pretty good discount. It may not be 140% of Medicare, but it's not 400% of Medicare either.
Right.
So the ability to pay quickly, the ability to ensure that the member responsibility will be taken care of, all that kind of matters ultimately to get somebody through and in.
Yeah.
And it's a shockingly low number of the number of times we have to tell somebody, this facility simply doesn't want your money. They don't want the plan's money.
Yep. And
you're better off getting your colonoscopy, right? Not at a hospital, but at an outpatient place that does it, 1,000 times a month. And it's going to be less than $1,000 to do so, and you're just better off going there. And most people are pretty coachable around that. They'll take the cue, and they want to save money too. And so sometimes it just kind of works out for the better. But I would say it's fractional.
Yeah,
0.3, 0.25 of all claims that we handle wind up with somebody being asked to go see a different provider, which we reach out to, make sure they accept it, make the appointment, maybe get 2 or 3 different options for them, and come back so they're not just sitting there going, well, who do I go see?
Right.
It's been well vetted and taken care of, and we put bubble wrap around that particular experience because it's really important. And we don't want people thinking that they don't have coverage. It's furthest from the truth. They have really good coverage.
Right. Yeah, no, that's amazing. I think about the way that your plan is set up and the custom plans that, we help our clients design on the healthcare consultant side of the business. And I think the amazing thing is you can't help but listen to a conversation like this and say to yourself, none of that is going on in a fully insured plan. Like the components, the elements you mentioned, stop loss, ag, coverage, all of that stuff, those are elements that are in any insurance policy. But when you think about the actual care piece and the fact that there's math behind these numbers, right? It's 80 to 85% of your spend is claims, and there's really no mechanism to control claims in a fully insured plan. How could you do anything but conclude, doesn't this just make sense? And I think the obvious answer is rhetorical. Of course it makes sense. The Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit Benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit Benefixa.com. So, but it wasn't, you didn't arrive here. The company wasn't started yesterday, and you arrived here today. So I think it's probably fair to say that this RBP model, and not just RBP, because ELAP is not all of RBP, right? The whole universe of RBP. You are a provider in the RBP space, with now you've grown an organization of 1,500 employees, I'm guessing hundreds, if not thousands of clients. And so it not being your first rodeo is kind of important as well, not only for the client, but for the broker that's bringing your solution to the table. But I think it's fair to say that it wasn't all, roses, and the path to where you are today probably had a few twists and turns, maybe a couple of bumps, maybe a couple of mountains. Tell me a little bit about, the ugly side of the early days, and then when did you come into the picture, and was it just kind of a changing of the guard, or was there a real mandate with hiring you as CEO to come in, and what did you walk into?
Yeah. So I started in 2019, and it was probably 3 years into Water Street's investment. And I was really taken with how successful they had been with what seemed like a very impractical approach. And when I looked at the numbers and saw the data and kept asking questions, it validated the fact that this is a different but very successful way of going about reimbursement. And they were on the cusp at that point of just bought a company that had a lot of direct contracts called Imagine Health, ironically. When we rebranded the business a few years later, we made it Imagine 360. But I think in the early years, it was, a bit bare knuckle. We strenuously defended the reimbursement, and we didn't have a lot of yield, and we had a lot of conviction that we were doing the right thing for the employer, that it's American families deserve better, and we're going to bring fairness back to healthcare, and we're going to advocate for the employer on their behalf, and we're not going to yield, and that worked. Because what that did is it put a framework in for the company to handle the worst situations, because there was no yielding, and so you are actually having a lot more of those because of the unwillingness to negotiate, unwillingness to pay small dollar balance bills out just because let's make life easier for folks. Not having direct contracts originally, and we debated, right, as a management team. Why would you ever want to do a direct contract? Because here's what's going to happen: they're going to bring you in at a low rate, and then 4 or 5 years from now, they're going to jack the rates back up, and they're going to have you because you've just told all your employees to go there and all your clients, and you're going to be right back to where you started. And so, we debated that a lot. And there were some people on the team who said we should be a pure play RBP company. That's it. But ultimately, I think the power of the and. You can be a great reference-based pricing company, and you can have direct contracts. And you know what else you can do? You can offer a dual option.
Yep.
So you could give employees who can afford a broad panel PPO the broad panel PPO.
Right.
But why tax everybody else in the company, particularly lower wage earners, with that very expensive, to your earlier point, that fully insured mindset where you're paying for a Cadillac or private air service when you should be in Southwest, right? Or be in an Uber.
Yep.
And so who are we to tell people what they can afford? We're just going to create an environment where we can give the lowest cost product that's available to the one that could be the highest. So we, 2019, I was hired to come in. The founders were still active in the business, and I really wanted them to stay on and with me and help me get to know the company better, and they did. They were both on our board, and for the past 5 years, they've been really active and really helpful.
I'm sure that's welcome because it's like a whole new ball game.
It's a whole new ball game. But I wanted it. I thought it was important, and they had built something so unique, and I think a really good culture. Like the people who work at Imagine 360. I talk to every single new hire that comes in, and the common thread is, I just wanted to feel good about what I do for a living. I wanted to make a difference. I wanted to change the way healthcare is working, and I'm not feeling it right where I am right now. And you guys, we're not perfect, right?
Yep.
We're just not. But we try really hard to make a difference. We try really hard to save and help an employer. And the cool thing about the company is there are so many ways in which you can help an employer or an employee save money on healthcare. It's almost endless. You got to pick your spots and do it and then execute it and make sure it works as designed and then make sure the client actually likes it before you then start doing another thing. Because if you don't, it becomes chaos, right? So having a pipeline of opportunities, having a roadmap of things we're going to be doing next, and rolling these things out every year to improve the process is not easy.
Yeah.
And so we couldn't do it all in 2019, what we're doing today. But we all had a vision, and the major vision was this: let's be resilient on how we can reduce the cost of care based on our reference-based pricing, mind share, and our history.
Yep.
But let's also own the member experience, because it was so frustrating to have other TPAs that we didn't own but worked with who had a very different philosophy of how a member should be treated. They didn't want to talk to them every single day about the status of something, where we were like, you have to do that. Or, they weren't maybe as good in terms of adjudicating claims accurately or succinctly, or their customer service was below average. And it was really frustrating because we would lose opportunities. We lose accounts because we didn't have really good service. And so the idea of owning the member experience end to end, not just for reference-based pricing related stuff or access to care, but for the day-to-day stuff, right? Hey, let's answer phone calls in less than 20 seconds. How hard can that be, right? Let's process a claim within 48 hours and pay it, quickly. Let's do the things that you'd want to do, right, from a health plan perspective that make people feel like you care about them as a person and a good experience. And so buying a couple third-party administrators really gave us a chance now to see the whole playing field and give us a framework and a vehicle to add other stuff that could be integrated. What we didn't want to do, though, is bundle everything and obfuscate what everything cost and how everything works together, because that's exactly what we're moving away from with the BUCAs, right? You've got the embedded pharmacy program. You've got the embedded area out of network program. You've got the TPA. You've got the contracts. You've got care management, and you've got telehealth, you name it, it's all in there. And the problem with that is it's not what we want these days. We want transparency so we can see what everything costs.
Yep.
We don't want to be told we have to.
And is that so much to ask for?
No, it's not. I mean,
Right.
how is it? You're the client, you're the broker, and you can't get your client's claim data. It's their data,
nuts.
right? It's their data. So
Yeah.
anyways, so what we wanted to provide was a one-stop shop if you wanted it.
Yep.
But always can unbundle in any way you'd like. But when we do that integrated solution, it wasn't to try to get more PEPM or more revenue or more margin. It was, how do we reduce the cost from 20% to 25? How do we get 25 to 30? How do we get 30 to 35?
Yeah.
Because RBP will do it, but if you don't use RBP, then you're back to, okay, it's contracts. And so maybe a couple direct contracts will get you 5%.
Right.
Maybe a transparent PBM program, which we just launched this year, Imagine RX, will get you 10%. Because we're making no money on anything to do with pharmacy. Rebates go back to the client. It's per script only.
Yep.
And we've subsidized the cost per script because we want to make it the most compelling thing. Like, you almost have to just look at it and compare it to where you are.
Yeah.
So objectively, we have tried to make money primarily on our reference-based pricing solution and TPA services and nothing else in the food chain.
Yep.
And do everything else almost at break even, with as long as it saves the employer money.
Yeah.
And we can build towards that, 10 to 15, 15 to 20, 25 to 30. And like a lot of your clients too, just like our company, we're different in 2025 than we were in 2019, and it took us 6 years to get here. Your clients aren't going to be ready to do all this overnight.
Right.
So they have to take baby steps and move in a direction, and you got to pick your spots with them to figure out, okay, what are they ready for? But they got to save something. I can't sell them 10% renewal again this year.
Right.
So I think a transparent PBM is a wonderful place to go to look. The problem is most fully insured won't let you carve it out. And even self-funded BUCAs get really cagey about letting you shop the PBM because it's a moneymaker for them.
Sure.
So that's always a good place to start. It really does probably lead to how transparent are they really. And then, just go level funded. Go level funded for the first time. It's not even self-funded. It's kind of a tweener where you can get somebody going in a direction where if they have a good year, they benefit from it themselves. And if they have a crappy year, they're still capped out at the fully insured rate.
Right.
But they get a flavor of being, for the first time, kind of in control of their own destiny when it comes to their healthcare costs. And it's addictive.
Right.
You've met a couple of folks that really have been really good friends of mine. Stephanie Koch, who she's great. She's great.
Yeah.
Right. And she rebuilt that health plan from scratch. And now she's doing things. I went to they're in Tampa, so I get over there once in a while, and they had a health fair. And the stuff that they're bringing now to the employees in the shipyard, it's fantastic.
Yeah.
Regenerix, which is like joint replacements with shots and spinning, that's now available for their employees.
Yep.
They brought in a low rate, somewhat subsidized by the company, first home down payment company.
Oh wow!
So you can actually get home ownership. She's really innovative.
So Stephanie Koch, for folks that didn't tune in, is an HR director, and she worked. I think it was in the boating industry. Was it not? Yeah, and she was at her wit's end because she was just frustrated with kind of the same old coming back from the broker. And it wasn't until she got directly involved and rolled up her sleeves that she figured out there's a different way to go about this. And, as most folks that I talk to about making that transition, it scared the shit out of her. But wow, it really created an amazing, not only I hate to use the word windfall because I don't want to sound sensational, but a huge amount of savings for the organization. And at the same time, the member experience was actually pretty good. And going into it, that's not typically what anyone, I think, reasonable is going to expect. They're going into it saying, hey, this is going to be a storm and we got a fight on our hands, but we're going to get through it. Now, I think, even Stephanie, we're talking about several years ago, every year it gets a little bit better. And I think that's kind of where I was getting at. Like I had, if you asked me maybe 2 years ago, maybe even as early as last year, is it appropriate for like a financial services firm with offices, primarily in New York, but maybe scattered worldwide, not a huge company, a few hundred employees, used to, a silver spoon in their mouth. These employees are coddled, and they have an excellent plan option. It's one or two plan options from United, just to pick a name. And the average cost or premium per employee per year is not $17,000, but it's closer to $30,000 in New York. Are you going to get them to swing over to an RBP model using an Imagine 360? And up to a year ago, I'd probably say no, certainly not an all-at-once kind of pedal to the metal, because to your point, you have to. It's a process. You need a talented broker or consultant to kind of help map this out, and in coordination with, not, there's not a dictatorship, but in coordination with the solution provider, in this case Imagine 360, the consultant, and the client, you can lay out a roadmap and say, okay, here we are coming into a 2026 renewal, maybe January 2026 we start here. And maybe there's an option with a major carrier network that employees have the option to use. But at least then, underlying, side by side with that, you have cost containment options that are built into the plan that are going to do what? They're going to reduce pharma from 30 to 60% of what you're spending today. That's 20 to 30% of your claim spend. It's going to reduce hospital, by 20 to 30%. And you start adding this up and it's like, holy crap. So it used to be that these types of solutions were not appropriate for those white collar, that the needy folks, the needy employees, right? The people that are well compensated and high up on the food chain. I think that that's changed, and I'd love your opinion because they were more suitable for the manufacturing businesses with low margins because, as we know, this is, typically the top expense after payroll is your healthcare expense. And so if you can save SG&A dollars, that drops right to the bottom line. Save $1 million, trade at a 10x multiple, you created $10 million in shareholder equity. Do that over and over again, you should have some pretty happy shareholders. And it boggles my mind, Jeff, that it's such a basic business concept. And yet, I tell people like the hardest thing that I've tried to do as a healthcare consultant is displace an incumbent broker who then goes back to the client and says, "Oh, Ray can't do that," or it won't be in your best interest. Right. And it amazes me because there's so much money at stake, and it's so frequently the wins are so few and far between. What would I see you nodding your head. What do you chalk that up to? Why is it so difficult to displace an incumbent broker? Even you, with all of the success of Imagine 360, you have an army of employees behind you. Why don't people pull the trigger more often?
It's a great question. We have, so just in terms of putting my money where my mouth is, we've doubled our sales team in the past 2 years, which has taken EBITDA down pretty substantially. Because we believe that it's coming, and that we got to be able to tell the story in the right way. We have to help brokers look at their book of business, and you're right. There's a gestation period here, and there are client types that have shown, at least so far, a propensity to lean in. And so we have this thing called the Rubik's Cube, and we look at your 100 clients, and we'll tell you the 20% of those clients that are the highest likely clients to see this particular solution and to buy it. And what we've learned along the way is you have to have sponsorship at the executive level, and either HR is on board or they're not. And when they're not, they need to be onboarded. Mm-hmm. Because if you don't have the executive sponsorship, if I can't, we're on our own program, yep. Right? If I can't stand up in front of our associates myself and say, my wife and I use the plan, and it's worked out great. Have we ever had an issue? Yeah, my wife was going to get a colonoscopy, and we could save her $2,000, and we asked her if she could change her day, and so she did it. And we did it proactively, and she thought it was actually kind of an interesting benefit that we offered. So I usually say, ask one of the C-suite folks, are you willing to sponsor the program, and are you willing to ask your employees to drive an extra 5 to 10 minutes to a different facility? Mm-hmm. If conceptually that would work, and at the same time you could say, and you'll probably save 10%, and you can give 10% back to your employees-ish on this 20% savings.
Yep.
And will you reinvest it? Because if you will, the employees will buy in, right? Because a typical health plan, the employer is paying 80% of the cost. Employees are paying 20%. It may be 75, 70, 30, but let's just use 80-20,
yep.
Right? And if we could save 10% of total health plan costs, and that goes to the employer, it's a huge win. The other 10%, if you save that, it's going to go to the employee. You've just cut their costs by 50%.
Mm-hmm. By the way, so I would say that if we're talking about a larger organization, I would agree with those numbers. But by and large, if we're talking 500 employees or less, or a business with low margins, I think it's closer to a 50-50 split. When
you take family considerations in,
employer,
and single
employee, yeah, and more employers, I think, in that bucket are opting to go with, will maybe cover 70% of the individual employee premium, but then you're on your own with the cost of the family members. And if you think about it, that's a huge burden. First of all, it makes it difficult for the organization, right? Because it's not, to your point, if you want to double your sales force and you have a crappy health plan offering, how are you going to attract the talent to double that sales force, right? So I think, big picture, the C-suite needs to be more involved. I agree completely, and they need to be more involved now more than ever for a couple of reasons. First of all, the sheer cost of the expense warrants their involvement, because HR people are great, but they're and I think it's becoming more a requisite skill set of an HR person to have a finance background because of this. But if they're out of their depth, they need an assist from the CFO, the finance team, someone to help them kind of with the numbers, right? Because it's really that critical. But when we talk about healthcare and benefits contributing to the culture and growth of an organization, it's not like a one-time shot, at renewal, we're gonna jump in and try to figure this out. No. It really is, I think at this point, it's an ongoing, part of the conversation throughout the year for most organizations. If we're talking about, small mom and pops, different story, of course, but we're talking about legit business entities that are out there and they're trying to grow their bottom line, grow as an organization. You got to pay attention to what's going on in healthcare. And if you're a CEO or CFO listening and you're not involved, get involved.
Agreed. And I think momentum and inertia is a very powerful thing. And so is fear, right? And so you got all this inertia with the way things have always been done. And they have the majority of the market share. And they love to play the fear card, and the biggest fear card where it works the most is usually HR.
Yeah.
There's concern about change management. There's concern that they may not be as adept in this type of product as they could or should be, and then, it's not really their job to do all the math. So I think getting that HR person, either with the CEO or the CFO, giving them permission to go figure this out and find some savings. Do it the right way, right? Let's not blow up our employees, but get us on the journey, get us started. I would say historically, I have not seen many high-end, white-collar entities all that interested. I met a small firm. It's actually in Tampa, and I think they do maybe debt raising and secondary market investing for secondary debt. It's not a big company. I think it's like 25, 30 people, no, maybe 50. And
they're well compensated.
Yeah, they're well compensated.
Yeah,
right. They do really well. It's a version of private equity, right? Just it's debt. The founders just one year said, I this is crazy. I'm a smart person. I feel like I'm being taken advantage of in my fully insured product.
Yeah.
I don't have any data. I don't love the experience my employees are having, and I don't have any control. So he had one of the really smart analysts that he had on his team. He said, for the next year, you are going to go and look at every single different health plan that's out there and figure out how we can get control of our healthcare costs again. And the kid, he's not a kid, he's probably 35, did his research and started looking and asked a lot of brokers and looked at this company and looked at Surest and looked at us and came back with a plan that is pretty much what you and I have been talking about.
Yeah.
And they've invoked it, and so we're in a dual option with a relatively small group. It's a lot of really wealthy people doing really well, but it's why would you give your money away if you don't have to? And if the experience can be equally as good, it's just the right thing to do.
Yeah.
Right, from how you spend your money and your people. And the other thing is, even the larger companies, right? So Raymond James is a large company in Tampa, right?
Sure. Financial services.
Big bank, a lot of independent wealth management. They also have they have investment banking, and they have a whole bunch of different areas of the company. It's huge. They are challenging themselves on how to get more cost-effective healthcare. And I know people on the benefits committee there, and we're friends out of work. And I've said, you should investigate some of the things that are happening in this alternative healthcare world. Not us, everybody.
Sure.
Look, and I think for the first time they're interested in really looking at something that would be innovative and new and different. And I think historically they've never even thought about it. And they have a lot of people there at Raymond James who are back office, right? in transactions and in customer service. And I think I was surprised at the percentage of people of a Raymond James or a bank that were making less than $100,000 a year from a family perspective. And that puts you right in the sweet spot of somebody who could really use the help.
Sure.
Because every dollar they get back, it's almost like it's a raise in many respects. And it's unaffordable. Like the thing that really ticks you off is we've created this game of where we are today, where we've done quite a bit of, to your earlier point, payment transfer, where it's almost 50-50 for some of these smaller companies in terms of who's contributing to the premium.
Yep.
And I guarantee they're not a no deductible plan, right? Right?
For sure not.
Right. $2,000-$3,000 high deductible.
The deductibles that essentially they're functionally uninsured.
Uninsured.
They can't afford their out-of-pocket
But
costs.
nobody ever says that. That's not in the industry. And everybody just kind of sits there and takes it.
Yeah.
And wouldn't it be great to say, let's take that same individual and maybe they have to contribute the same.
Yeah.
But maybe they're on a copay plan because we're going to subsidize some of that with the savings that we get, and we're going to ask you to do some things differently. Or keep the high deductible. When you need it, use it. But we're going to reduce your contributions pretty substantially. I don't know. So there's a broker that I've gotten to know really well in the Atlanta area, and he's been a long-time seller of Imagine 360, and he's one of those type of person that will let you know how we're really doing.
Yep.
You know, I talk a lot about the things that we do and do well, and I think generally we're pretty good. But he lets me know when we're not living up to our expectations, his expectations, and that could be anything from turnaround of a service or how it felt for one of his employers to renew with us or whatever it is, right?
Yeah, sure.
But a really, really good point of feedback. And he was spending weekends with his wife on their dining room table, helping the handful of employers that he works with who have pretty low wage earners fill out financial assistance forms at hospitals that they had recently gotten care from because they couldn't afford the $5,000 deductible, but they had to go. It was an emergency. So they're sitting there with a $5,000 bill. They don't have $5,000.
Right.
And I think 40% of the U.S. Would tell you that they have medical debt. I think it's 40-50% have some form of medical debt today.
Over 100 million people.
100 million people
in the U.S. that have some form of medical debt.
Which is pretty crappy.
Yeah.
Right. And then secondly,
practically a third of our country.
Right. I think a similar number probably has less than like $4 or $5 grand for discretionary purposes to use in the case of emergency.
Less than $500 is the last statistic that I heard.
Yeah. Right. Okay. So that's pretty dire, right?
Yeah.
So what he figured out was that hospitals, because of the ACA, both profit and non-for-profit, are responsible for providing financial assistance.
Yep.
And it's a formulaic, and it's up to 400% of the poverty level. Sometimes it's more.
Yeah.
And that's a lot of people who don't know and should know that they're out of pocket to go to a hospital should be fully covered by the hospital. They don't really, the hospital system doesn't bring it up proactively.
Right.
And so with his encouragement, we went down a path of investigating that from a business perspective.
Okay.
We started a company called Upland Health. It's part of Imagine 360. So we now embed in every one of our clients a screen for financial assistance. And we get your zip code and we get your annual income. It's pretty accurate in terms of who's going to qualify and who's not. And we can do it proactively before you go get care to make sure that if you qualify, you don't pay anything. Or if you have medical debt and you've had it in the past year or two, we'll come in and we'll go negotiate and get it taken care of. Either get it fully waived because you should have been on financial assistance, you just didn't know it.
Right.
Or at least come up with a payment that we can do a one-timer and get them out of an interest payment plan, like a no-interest plan that we can find and help them with and retire it. It's a really cool way of kind of giving back and adding some value. And that particular population of an employer group needs the help.
Sure.
And there's more applications, I'm sure, that you could think about. Maybe the people who don't take the insurance coverage who are uninsured.
Yeah.
But at least the ones who have coverage, we're going to make sure we get them everything they're possibly due and then some by ensuring and making sure they have financial assistance. And some really cool, really cool stories that have come out of that program.
That's
and that
interesting, for sure. So as we wind down, I'm curious about, what do you think of, the name of the show is Broken Healthcare. What do you feel the state of healthcare is in the U.S.? And I know there's plenty of good and there's plenty of right with it, but what's your take on it? And what do you see as the future? Because over 160 million, thereabouts, Americans get their coverage through their employer. Do you see, Marshall Allen, the great Marshall Allen, the investigative journalist that we lost, prematurely a couple of years back, wrote a book called Never Pay the First Bill. And he was the first guy that I heard speak at a conference about we're in a healthcare bubble. And when I heard that, it really resonated with me. And I said, I never heard anyone put it quite that way, but I do believe that we are in a healthcare bubble. Do you agree with that first of all? And secondly, Jeff Bezos is famous for saying their margin is our opportunity. Is that kind of how you feel about what you have going on at Imagine 360? How big is the addressable market? And what do you think the future of Imagine 360 looks like?
Yeah, it's a very big market. And I think all the alternative health plans out there today, so non-BUCA, right? Maybe you throw Kaiser into the BUCA arena. I think we make up 5% or less of the total market. So you have 95% in a product that is not sustainable from a cost perspective, not very transparent in terms of what you actually are paying and for what. And we know there's just a ton of margin in the pharmacy arena. And, it's kind of sad. We've talked to some states, and these are first responders. And I won't point out the North New England state, but it's a state in New England. And the first responders' total cost of health care is $50,000 a year for a family. Yeah.
That's crazy.
Yeah. And it's in a broad panel PPO administered by one of the BUCAs.
Yeah.
And these are dollars that they would be otherwise getting in terms of pension, or salary, but it's going into health care. And it's not like it's free. They have a deductible as well.
Yeah.
And you look at that and you say, well, who's the benefactor of a framework like that? The hospitals,
right?
Because they get paid really well.
Yep.
From a very rich plan, and there's not a lot of pressure to have them reduce their contracted rate.
Right.
And then the intermediary, the middleman, the BUCA, the person who's
insurance carrier, the PBM that they own.
Right. So that to me is just it's a wake up call. It's a wake up call to start. 20 years ago, we owned a Taft-Hartley TPA, called ABPA, which became Zenith American, and one of our largest accounts was the culinary workers out in Vegas, and I was relatively new to unions and the way those things worked. I didn't really understand the full Taft-Hartley, but they're a payer. They're a payer like an insurance company are, only the union has collectively bargained for a lot of the union members. And it's almost like a self-funded employer, right? It's a contract and an entity that now has responsibility for finding the best health care they possibly can. So this is 20 years ago in Vegas. They picked one hospital and did a direct contract with them. Everybody else, they said you're going to get 200% of Medicare, that's it. They have a near-site on-site clinic, which they put in the union hall. So you could go there to get free drugs. So all your drugs were free, except for specialty. And primary care was right there. And like 20 other things that you would just do if you cared and you were a good custodian of care and it was your job to manage a health plan. Mr. Employer, you're out there. You are a health plan, whether you realize it or not.
Yep.
And Stephanie can show you the 20 steps that you need to take to be a health plan if you're going to be an employer, but you're a payer. And I think hospitals forget that the biggest payer is not Medicare. The biggest payer are employers who are self-funded, and they're basically right now haven't mobilized.
Right.
They haven't been given the tools. They haven't been able to take the next step. But like a lot of change, it's slow and forever. Like our market share, like for all of RPP plans everywhere, is less than 1%.
That's insane.
And it's been 10 years.
Right.
But like Bezos may tell you, it's hard to get the first percent, and then a switch happens.
Yep.
And it's on us to make sure that it's easy to use. It's on us to make sure that people are educated. It's on us to make sure that the right narrative is out there about what really happens.
Yeah.
But when it turns, when that tide turns, the speed in which things can change and how people will quickly react and want to make a change.
Yeah.
We've all seen it, right, in other walks of life. So I tell my team this all the time. It's coming.
Yeah.
I don't know exactly when. I hope I'm still working when it does come, because it'd be really a lot of fun to see the disruption.
Yeah.
Our job is to keep chipping away.
Yep.
And keep listening to our broker partners, keep listening to clients and customers on what can we do to be more mainstream. What else can we do to get you more comfortable with what we do and how we do it? We'll do it.
Yeah.
I mean, we'll figure out a way to do it, because it's the right thing to do.
How much do you think it's about, without going down, like, I don't want to put you in an awkward position. So this is a hypothetical. How much do you think it's about the collusion, for lack of a better word, between an insurance carrier and their broker sales force, the majors out there, the Marshes, the Aons, the privately held brokerages, the Locktons, the ones that are making a phenomenal amount of money, and they're doing it, with compensation that's disclosed. And even though they're supposed to be disclosing all compensation, there's undisclosed compensation. And then I'm talking about the trips out to the Masters tournament, and the trips to Pebble Beach, and the private yachts, and the this and the that. How much of that do you think realistically is holding back a solution like yours and other independent broker consultants like ours from gaining a larger market share?
I think you should be thanking them for the way that they are currently behaving and what's entrenched, because it's a hunting license. Yeah. It's a hunting license to go in and put a spotlight on something that could be very different and retell the story that it's not pandemonium and it's not a horrible experience. And we did so Bain came in and did a study on Imagine 360.
Yep.
They looked at, they asked like 100 brokers, hey, tell me what reference-based pricing means to you and how it works. And roughly what are the numbers? And they're like, oh, it's the worst. I mean, you get balance billed 50% of the time, and 25% of the time you can't access care. I would never. And they said, well, okay, fair enough. Do you consider yourself an expert? Yeah, I'm an expert on reference-based pricing. So half of the brokers said they were experts, but only 2% of the brokers could cite the real data
Numbers
and statistics as to what's happening on the ground. So they said, hey, if it was this good, a 3% balance bill rate, a 99.5% access to care rate, would you sell? We'd sell it tomorrow.
Sure,
absolutely, we would.
They would.
Right? That's what they said. That was what the data said.
Right.
So I think it's people like yourself.
Yeah.
That and we have, we call them, the Mavericks.
Yeah.
That are looking to do the right thing, partner with a company that's going to have their back. You're not going to win every time, right? But at least you've got something to talk about that is new and innovative, and you could show them a path of 2 or 3 years from now of real material savings. And that doesn't ever go out of style. And I think there's going to be more and more. Like right now, I told you about the Cube earlier.
Yeah.
The Cube, and it's wonderful, but it is limited to who you think would typically want to be saving the type of money that we're saving them. Auto dealers, trucking, nursing homes. And every year it expands a little bit, but it's the lower wage, higher turnover industries that are really struggling, and they need help now. They don't have the time. But there's plenty of those to go out and talk to and try to educate. And I'm if I was starting my career right now, I have a son who's actually starting in the property and casualty side of the business. And I asked one of my buddies who's there forever, I go, what's your reference-based pricing in P&C? Do you have something that you can give these young folks a hunting license to go do and educate and really transform? and they mentioned captives and some other things, but nothing quite as compelling as the opportunity in healthcare to literally reduce the cost by 20 or 30%, and it's sustainable. And that just doesn't happen very often. So I do think there's a really interesting opportunity for people who want to listen, and you can point out in your pitch some of those trips and things that you see people doing, and ask those guys if they get it disclosed.
Well, I just wonder, and most of the times, if I talk to someone about this and they say, really the CEO of a company with 10,000 employees can buy their own trips and blah, blah, blah. And yeah, that's true, but it's really nice when someone else is paying for it. That's all I'm going to say about that.
It is, right? Yeah.
It's really nice.
It is nice.
So I think we're going to leave it there. How do people find you if they want to connect? Would they connect with you personally? Would they connect with someone on your team? What's the best way to learn about Imagine 360?
Yeah, you can go to our website, imagine360.com, and it's it takes you through the history, the company, the services. I'd love to hear from any of your audience, particularly if they have a question or a follow-up, or if they want to get started. I would love to introduce anybody who's out there interested that wants to get educated on what we do and how we do it. We have a certification process that helps new producers really get up to speed quickly. And you learn a lot, and we have a lot of really good, strong people in the field who will participate with you on that first and second and third pitch, so you get comfortable, right, with some of the questions and some of the pushback that we get, and more importantly, right, a way to combat what the incumbent's going to say about what we do and how we do it. But you can reach me. You can reach me at really any time at jbak@imagine360.com. Would welcome to learn more how we can be helpful, and really appreciate the time here today.
Awesome. Well, hey, it's been a pleasure having you, Jeff. Really appreciate you joining us. I learned a lot. I'm sure the audience learned a lot. So until next time, folks, love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.